99,000 people. I mean, just let that number sink in for a second. 99,000 avoidable deaths. And that is every single year in United States hospitals alone.
Yeah, and it's crucial to point out that these aren't from, incurable diseases or some mystery pathogen.
Right, exactly. According to this landmark report by the U.S. Institute of Medicine, those deaths are caused purely by the inadequate or just completely incomplete implementation of evidence-based practices. And, if that doesn't completely blow your mind, consider this stat. It takes an estimated 17 years for a proven health intervention to actually make its way from a published discovery into routine clinical practice. 17 years.
It is a totally sobering reality check, isn't it? I mean, for those of you listening right now, whether you're a medical student, a public health trainee, or, a practicing clinician, you spend years, sometimes decades, mastering biomedical sciences. You're grinding through pathophysiology, pharmacology, surgical techniques.
Oh, yeah. Endless flashcards.
Right. But the data clearly shows that discovering a cure is, frankly, only half the battle. If we can't actually deliver that cure to the patient efficiently and reliably in the real world, the discovery is functionally useless.
Exactly. So for this deep dive, I want you to visualize this gap as a massive, turbulent river. On one side, you've got this gleaming, highly advanced metropolis, right? This is the city of scientific discovery. It's packed with miracle drugs, state-of-the-art diagnostics, researchers just churning out medical breakthroughs.
The ivory tower, basically.
Exactly. And then on the other side of the river, you have the people who actually need these miracles, the global population suffering from preventable or treatable conditions. And connecting them is a bridge, but it's a bridge under construction. It just stops halfway across the water. So all these cures, all these updated guidelines are just piling up on the edge of the precipice, unable to actually reach the other side.
I love that image because that incomplete bridge perfectly encapsulates the mission of our discussion today. We're diving into Chapter 6.9 of the Oxford Textbook of Global Public Health, and we are looking squarely at implementation science.
The science of building the rest of the bridge.
Exactly. It's the rigorous scientific study of how to close that massive chasm between what we know works in theory and what is actually delivered at the front lines of care.
And, getting into this requires a really fundamental paradigm shift in how we even think about medicine. We're moving away from evaluating just clinical efficacy, which, simply asks, does this drug work in a highly controlled, perfectly sterile lab setting?
Right, the perfect conditions.
Yeah. And we're moving toward implementation effectiveness, which asks a much messier, but honestly much more vital question. Can we get this drug into a patient's system in the middle of a chaotic, underfunded, real-world clinic?
And that distinction between efficacy and effectiveness, that is the absolute bedrock of this entire field. We so often fall into this trap of viewing public health failures as a lack of scientific knowledge. We tell ourselves, oh, if we just had better technology or if we had a more potent molecule, we'd solve the problem.
It's always about the next big breakthrough.
Always. But the text gives us these two harrowing global examples that prove knowledge is rarely our actual bottleneck. Let's look at tuberculosis first.
Oh, man, the TB stats in this chapter are genuinely staggering. I mean, we have known the biomedical cure for TB for over 60 years. The pharmacology is totally settled. The multi-drug regimens are incredibly effective.
Yeah.
And yet, the text points out that in 2011, 1.4 million people still died from tuberculosis. Over 1 million people dying annually from a disease we have known exactly how to cure for more than half a century. The bridge is incomplete. The cure is just sitting on one side, and patients are dying on the other.
It's tragic. And the second example the text explores is HIV/AIDS, which paints this equally devastating picture of implementation failure. So antiretroviral treatments, ARVs, they are highly effective at saving lives and suppressing viral loads, right? To the point where the virus literally cannot be transmitted.
Right. U equals U. Undetectable equals untransmittable.
Exactly. Yet in 2011, only 48% of co-infected TB and HIV patients received these life-saving medications. Less than half. And the failure becomes even more acute, like really glaring, when we look at PMTCT, which is the prevention of mother-to-child transmission.
Yeah, and the biomedical intervention for PMTCT is nothing short of a miracle. I mean, the clinical data shows that administering ARVs can drop the transmission risk from a mother to her baby from roughly 25% down to under 2%. That is basically a silver bullet.
It's an absolute triumph of clinical efficacy. But the implementation effectiveness, that's a completely different story. The text notes that in the highest burden countries in East and Southern Africa, only about 50% of pregnant women are even tested for HIV.
Wow, just 50%.
Oh, yeah. And you can't administer the ARVs to drop the transmission rate to 2% if you haven't even identified who is carrying the virus. So as a direct consequence of that systemic failure to deliver a well-established intervention, nearly 370,000 babies are infected with HIV each year.
To really wrap your head around how these failures compound, the text introduces this really vital conceptual framework called the cascade of care. And it uses the U.S. HIV continuum as a primary example to map out exactly how and where health systems just leak.
Leak is the perfect word for it.
Right. Because if you think of a patient's journey as this sequence of mandatory steps, the cascade visualizes the attrition at every single stage. Let's break down the anatomy of this cascade because it is terrifyingly illuminating.
So the cascade starts with the total infected population. In the U.S., at the time of the data presented in the text, there were roughly 1.17 million people living with HIV. So that's our denominator.
Oh, yeah, 1.17 million.
Right. Now, the very first step required for treatment is diagnosis. And the data shows this immediate, massive drop-off. Out of 1.17 million infected individuals, only about 941,000 are actually diagnosed.
So just at step one, the system has already lost over 200,000 people. They're carrying the virus, but they are completely unaware.
Exactly. And then the next step is linkage to care. Because getting a positive test result isn't enough, you have to actually be connected to a medical provider who can manage the disease.
Right, you need a doctor.
Right. And here the number plummets again, down to about 725,000 people. And following linkage is retention in care. Because HIV is a chronic condition, it needs lifelong management. One clinic visit doesn't do it. So when we look at how many people are consistently retained in the medical system, the number drops massively to roughly 480,000.
That is insane. I mean, we started with 1.17 million people, and merely by trying to keep them showing up to appointments, the health system has bled out more than half of its patient population. We're down to less than 500,000, and we haven't even handed them a single pill yet.
And that brings us to the next step, prescription. Of those 480,000 retained in care, how many actually get prescribed antiretroviral therapy? That number falls to 426,000. And then finally, we reach the clinical finish line achieving viral suppression, where the virus is undetectable in the blood. Out of the original 1.17 million people infected, only 328,000 achieve viral suppression.
Wow. When you lay it out like that, the whole illusion of the biomedical silver bullet just completely vanishes. The ARVs work perfectly. The molecule does exactly what it was engineered to do in the lab. But every single drop-off point in that cascade, from diagnosis to linkage to retention to prescription, represents a distinct failure of implementation.
And the thing is, this cascade framework is universally applicable. You can map the exact same pattern of attrition onto hypertension management or diabetes care or surgical follow-ups. The fundamental pattern of how health systems leak is remarkably consistent across diseases.
Okay, so this is where I want to push back a little, or at least voice the skepticism that I think a lot of medical professionals might have when they first hear this. A clinician listening right now might argue, okay, if I have a patient with HIV and the clinical guidelines clearly say I should prescribe ARVs, but the patient fails to show up for their follow-up appointment, isn't that just a compliance issue? Or, if a doctor forgets to order the test, isn't that just bad doctoring? Why do we need an entirely new scientific discipline to tell doctors to follow the rules and patients to take their meds?
It's such a common reaction. But it relies on a fundamental misunderstanding of how healthcare actually operates at scale. Blaming the individual clinician or, labeling the patient as non-compliant completely ignores the massive structural realities defined in the text as the technology to systems gap.
The technology to systems gap.
Yes. When a new technology, whether that's a rapid diagnostic test or a new pharmaceutical is introduced, the surrounding health system does not just magically and automatically reorganize itself to accommodate it.
Right, because the system has all this structural inertia. It was built for older paradigms.
Exactly. Let's apply this to the PMTCT example. If you blame a doctor for failing to test a pregnant woman for HIV, you are isolating that clinician from their actual environment. Consider the context. Does the clinic's supply chain actually deliver rapid test kits reliably every Tuesday?
Usually no.
Right. And does the clinician have the requisite 15 minutes to provide culturally sensitive pre- and post-test counseling? Or is their waiting room overflowing with 60 other patients? And if the woman tests positive, is she deterred from picking up her medication because of severe social stigma, fearing her husband will discover her status? Is the pharmacy geographically accessible?
So it's not a knowledge deficit.
No, the technology to systems gap dictates that clinically vital discoveries are routinely held hostage by infrastructural, logistical, and social constraints. Implementation science is the rigorous study of how to redesign the system itself so that the technology can actually survive the journey to the patient.
That makes so much sense. So to locate exactly where this science lives, I think we need to look at the broader landscape of medical research. We're all familiar with the standard pipeline of drug development, phase 1, phase 2, phase 3 trials. Where does implementation science actually fit into that whole taxonomy?
Well, the text uses the framework established by the National Institutes of Health, the NIH, which classifies medical research into 4 translational steps, labeled T1 through T4. So the pipeline begins with basic scientific discovery in a lab. The first translational step, T1 translation to humans, involves early physiological studies and phase 1 clinical trials. The core question here is really basic. Is this molecule safe, and does it behave in the human body the way our animal models predicted?
Right, so that's purely exploratory. You're just making sure it doesn't cause immediate harm.
Exactly. Then the next phase is T2 translation to patients, and this encompasses phase 2 and phase 3 clinical trials, which test for clinical efficacy. Now, T2 research is conducted in highly sanitized, tightly controlled environments. You select a specific cohort of patients, you rigorously eliminate outside variables, you monitor their compliance obsessively, and you measure the clinical outcomes.
And this is the phase that generates the big headlines, right? A drug passes a phase 3 trial, the FDA grants approval, the medical community updates its guidelines, and historically, we've kind of treated T2 as the finish line.
We have. But as we've established with our metaphor, T2 only gets the materials to the edge of the river. This is exactly where implementation science takes over, occupying the T3 space translation to practice. T3 includes phase 4 clinical trials, health services research, and dissemination studies. It asks a fundamentally different question. How do we integrate this proven intervention into routine clinical practice across wildly diverse, under-resourced, real-world environments?
Okay, so that's T3. What about T4?
T4 broadens the lens even further translation to population health. If we successfully implement this practice widely, does it actually shift the epidemiological needle? Do we see improvements in global health metrics and social determinants of health? The crucial takeaway for you listening is that implementation science fundamentally rejects the "if you build it, they will come" mentality. You cannot simply publish a finding in a high-impact journal and expect thousands of disparate health systems to seamlessly adopt it by Monday morning.
It's just not going to happen. And to break that illusion, it seems like we have to pull knowledge from outside traditional biomedicine. The origins of implementation science are deeply multidisciplinary. The text highlights the profound influence of W. Edwards Deming, who was this foundational figure in industrial engineering and quality management.
Yes, Deming is renowned for revolutionizing manufacturing processes, particularly in post-war Japan. His conceptual framework is known as the system of profound knowledge, and it's highly applicable to public health.
Which I have to say seems completely counterintuitive at first, like applying the principles of a Toyota automobile assembly line to a hospital ward. But when you break down Deming's framework, the parallels are pretty striking.
They really are. Deming's system rests on 4 pillars. First is an appreciation for systems understanding that a hospital is a network of interdependent processes, not just a collection of autonomous doctors. Second is an understanding of variation analyzing why outcomes differ from shift to shift or clinic to clinic.
Right, why does Tuesday look different than Friday?
Exactly. Third is a theory of knowledge. How do we actually define and measure improvement? And fourth is the psychology of change understanding human behavior, motivation, and resistance. Implementation science basically marries this industrial operations research with behavioral economics and sociology.
Okay, let me interject here because there is a potential point of confusion, especially for those working in global health. Donors and health ministries, they are constantly demanding monitoring and evaluation, or M&E. They collect vast amounts of data on clinic performance. So how does implementation science differ from routine M&E? Because they both seem really focused on measuring what happens in the clinic.
It's a great question, and the text draws a very sharp boundary between the two. Routine monitoring and evaluation is primarily descriptive, and it's retrospective. It measures the services provided. It asks questions like, how many vaccines were administered this month, or how many patients attended the clinic. M&E measures the outputs of the system as it currently exists.
Okay, so it quantifies the gap, but it doesn't explain it.
Precisely. If M&E reveals that only 48% of patients receive their medication, its job is largely done. It flags the issue. Implementation science, conversely, is a rigorous, hypothesis-driven discipline that investigates the etiology of that gap. It seeks to understand the why and the how. It treats the system failure as a pathology to be diagnosed, and it designs and tests specific strategies to alter the system's behavior.
And that diagnostic process is incredibly difficult because health systems are notoriously resistant to change. The source text identifies 4 fundamental, quote-unquote, wicked problems that complicate the science of implementation. These are the structural barriers that make building our metaphorical bridge so challenging. Let's look at the first one, the problem of scale.
The problem of scale represents, honestly, one of the greatest tragedies in public health. The text cites data showing that out of 7.6 million deaths in children under 5 years of age, 63% are entirely preventable through the universal application of just 23 existing evidence-based interventions.
Wait, just 23?
Just 23. The clinical knowledge to prevent those deaths exists today. The barrier is scaling those interventions globally.
And we see this pattern constantly in the medical literature. A well-funded research team will descend on a single hospital. They bring extra staff, great money, intense focus. They implement a new protocol, say, an advanced maternal hemorrhage intervention, and it was a massive success. They publish a paper showing a huge reduction in mortality. This is the classic pilot study. But then, when health ministries mandate that every other hospital in the country replicate that exact protocol, the results just completely evaporate.
Exactly. And the text uses the example of rapid response systems, or RRS, to illustrate this phenomenon. An RRS is a clinical intervention where a specialized team of critical care experts is summoned to a patient's bedside at the earliest signs of physiological deterioration, aiming to intervene before a full cardiac arrest occurs.
Right. The physiological logic is totally sound. Early intervention prevents catastrophic outcomes.
And in early single-center pilot studies, these rapid response systems function beautifully. They led to significant reductions in inpatient mortality. Based on those pilots, major national and international campaigns aggressively pushed for the widespread scale-up of RRS across thousands of hospitals. However, when studied at scale, the results were highly heterogeneous. Many hospitals experienced no mortality benefit whatsoever.
Why? What broke down?
The mistake was that the medical community scaled the clinical intervention, the concept of the team, but they completely failed to study and scale the implementation strategy. They didn't account for how to integrate that team into differing ward cultures, or how to manage the power dynamics between the ICU doctor swooping in and the floor nurses, or how to secure leadership buy-in across diverse institutions.
Which flows directly into the second wicked problem, the problem of context. You cannot treat a health intervention like a software update that you just mass install across different machines. The text cites the epidemiologist John Ioannidis, who analyzed 45 highly cited, evidence-based medical practices, and he discovered that 1/3 of them could not be successfully duplicated when moved to new contexts.
Right. Context is the invisible variable that dictates success or failure. The text provides a brilliant summation of this regarding that RRS failure. It says, an RRS is not a drug treatment. A hospital is not a body.
I love that quote.
It's so good. A pharmaceutical interacts with human physiology, which remains relatively stable whether the patient is in Tokyo or Toronto. An implementation strategy, however, interacts with a complex adaptive system. It interacts with local financing, organizational hierarchy, staff morale, historical institutional culture.
Right. I mean, a clinical protocol that relies on really intense egalitarian collaboration between doctors and nurses might work perfectly in a progressive modern teaching hospital.
Yeah.
But it's going to face massive friction if you just drop it into a highly hierarchical traditional clinic where nurses are culturally discouraged from questioning physicians. The context fundamentally alters the mechanism of the intervention.
Exactly. And this profound influence of context introduces the third wicked problem, the problem of method. How do we scientifically evaluate interventions in these messy environments? The gold standard of biomedical research is the randomized controlled trial, the RCT. It's flawlessly designed to isolate a single variable by locking down all other conditions.
But if a hospital is a complex adaptive system, locking down all the variables is literally impossible. You can't freeze the culture of a hospital for 5 years while you run a trial.
You really can't. Applying a traditional RCT to evaluate an implementation strategy is often an epistemological mismatch. Standard RCTs are designed to answer, does this work under ideal conditions? Not, how do we make this work in a dynamic, unpredictable environment? The methodologies required to study implementation are entirely different, which we'll explore when we discuss study design in a bit.
The fourth and final wicked problem is perhaps the most deeply entrenched barrier, because it's rooted in human psychology. It's the problem of overconfidence, which really manifests as practice variation. There is this pervasive assumption in medicine that because clinicians are highly educated, rational actors, they will automatically adopt the best evidence once it's presented to them.
Oh, and the empirical data just fiercely contradicts that assumption. The text references decades of research demonstrating massive, unwarranted variations in how physicians treat highly standardized conditions, like pneumonia, heart failure, myocardial infarction. If clinical decisions were driven purely by objective evidence, treatment patterns for a standard pneumonia case should be nearly identical across different regions.
But they aren't. Two hospitals in the same city might have entirely different treatment patterns. Heck, two doctors on the exact same floor might manage the same condition differently.
Exactly. And this practice variation is rarely malicious. It's a byproduct of cognitive load, peer influence, local customs, and the specific constraints of a clinician's environment. Physicians are human beings operating within a system, relying purely on their clinical autonomy and expecting them to independently overcome systemic friction is just a recipe for implementation failure.
It's totally analogous to highway safety, right? Like, if we want people to drive safely, we don't just hand them a dense 200-page manual of traffic laws and tell them to use their best judgment. We engineer the environment. We paint clear lanes, we install rumble strips, we synchronize traffic lights, we build cars with automatic braking. We design the system so that the safest action is also the most intuitive default action. But in healthcare, we spend all our time writing the medical manual and almost no time engineering the clinical highway.
That is the perfect transition to how we actually build the bridge. If the problems are scale, context, method, and human behavior, what tools do implementation scientists actually use to engineer that clinical highway? The text outlines a comprehensive toolbox of implementation strategies, and it's vital to remember here that in this field, the strategy itself is the intervention being studied. We aren't testing if the vaccine works. We are testing the best method to get the vaccine into the patient's arm.
Right, and the text categorizes 10 primary strategies for driving change. Rather than just listing them like a textbook, let's group them conceptually to understand how they manipulate different levers of the health system. So the first group relies on top-down and structural changes. This includes executive mandates, laws and regulations, and pay for performance.
Right. These strategies utilize authority and economics. An executive mandate is a direct top-down order from leadership. For example, a hospital CEO mandating strict hand hygiene protocols. Laws and regulations utilize the power of the state, such as legislation mandating seatbelt use or altering the legal scope of practice for allied health professionals. And pay for performance taps into behavioral economics, explicitly tying financial incentives or penalties to specific clinical metrics.
But while those are powerful, top-down levers often face intense resistance on the ground. An executive mandate without frontline buy-in usually just leads to malicious compliance. And financial incentives can create perverse outcomes where clinics cherry-pick the healthiest patients just to hit their metrics. So we need the second group of strategies, which are cognitive and informational. This includes guidelines, clinical protocols, and training.
This group addresses the knowledge gap. Guidelines are the broad, evidence-based recommendations published by academic societies. Clinical protocols are the local adaptation of those guidelines, translating a dense 200-page academic document into a specific, actionable flowchart for, say, a local emergency department. Training involves the active transfer of this knowledge through workshops, simulation, or continuing medical ed.
But as we just discussed with the problem of overconfidence, information alone rarely changes behavior sustainably. You can train a doctor perfectly, but if the system is broken, the training is moot. Which brings us to the most robust group of strategies, system redesign and support. This includes checklists, task-shifting campaigns, and quality improvement. Let's dig deeply into task shifting because it profoundly alters the sociology of care.
Task shifting involves structurally changing who delivers specific types of care, or where it's delivered, in order to bypass systemic bottlenecks. If a country faces a critical shortage of physicians, the traditional approach is to build more medical schools, a process that takes decades. Task shifting approaches the problem laterally. It analyzes the clinical tasks and asks, can a highly trained nurse safely manage routine antiretroviral prescriptions? Can community health workers be trained to diagnose and treat childhood pneumonia with basic antibiotics? By shifting tasks to different cadres of workers, you drastically increase the system's capacity and accessibility.
It just bypasses the bottleneck entirely. Another structural tool is the checklist, which obviously got popularized in surgery. A checklist does not teach a surgeon how to operate. It functions as a cognitive net. It acknowledges that human memory is fallible under stress, and it structurally enforces reliability for critical steps, like administering prophylactic antibiotics.
Absolutely. And then campaigns operate on a macro level, utilizing social mobilization and peer pressure. Initiatives like the WHO's 3x5 campaign or the Institute for Healthcare Improvement's 100,000 Lives campaign set these massive, highly visible targets, creating a sense of urgency and collective momentum across thousands of disparate institutions.
The final, and perhaps most intricate strategy in the toolbox is process improvement or quality improvement, QI. The text highlights this with a detailed breakdown of the model for improvement. This is where Deming's industrial engineering truly manifests on the clinic floor. How does a healthcare team actually execute QI?
The model for improvement is profoundly democratic. It empowers the frontline workers to diagnose and fix their own system. It begins by forcing the team to answer three rigorous questions. First, what exactly are we trying to accomplish? This requires a specific time-bound aim, not we want to improve maternal care, but we will reduce postpartum hemorrhage rates by 30% in the next 6 months.
Clear, measurable goals. And the second question,
How will we know that a change is an improvement? This demands baseline measurement. You must collect data on your current performance so you can objectively evaluate if your new strategy actually moved the needle. And the third question asks, what specific change can we make that will result in improvement? This is where the team brainstorms structural changes to their workflow.
and crucially, they don't just implement the new idea hospital-wide immediately. They test it using a PDSA cycle. Plan, do, study, act.
Yes, the PDSA cycle is the engine of rapid iterative learning. You plan a highly localized test of your new workflow. You do it on a micro scale, perhaps testing a new triage form with just one nurse on one shift for one afternoon. You study the immediate results. Did the form cause confusion? Did it slow down intake? Finally, you act on that data. If the form failed, you discard it or modify it. If it succeeded, you expand the test to the entire department. This iterative process prevents massive, costly implementation failures by validating the strategy on a small scale first.
So having explored these strategies, we arrive at the methodological core of the chapter, designing the science. If we are deploying these complex strategies like task shifting or iterative PDSA cycles across dynamic health systems, how do we scientifically measure their success? How do we prove that our implementation strategy actually worked?
To map cause and effect in a complex system, implementation scientists utilize a rigorous four-stage measurement continuum: input, process, outcome, and impact. The text provides a highly instructive example regarding the elimination of congenital syphilis in Haiti. So the biomedical intervention is straightforward, administering penicillin to pregnant women who test positive. The implementation strategy chosen was a quality improvement collaborative, aiming to train clinics to reorganize their prenatal screening workflows.
Let's walk through the 4 stages of measurement using that Haiti example. We begin with input measures.
Input measures assess the resources dedicated to the implementation strategy itself. In the Haiti program, an input measure evaluates whether the training actually occurred. Did the instructors arrive? Were the diagnostic test kits and the QI manuals delivered to the clinic? If the inputs are absent, the strategy cannot begin.
Okay, assuming the inputs are present, we move to process measures.
Process measures evaluate fidelity. Did the clinic staff actually execute the new strategy as intended? Are the clinical teams holding their mandated monthly PDSA meetings? Are they actively analyzing their patient flow data? You can provide all the training inputs in the world, but if the staff refuses to adopt the new process, the implementation fails right here.
And then the 3rd stage is the outcome measure. But crucially, in this field, this is the implementation outcome, not the clinical outcome.
That distinction is paramount. The implementation outcome assesses whether the strategy successfully delivered the biomedical intervention to the target population. In our example, we ask, what percentage of pregnant women were successfully screened for syphilis? And of those who tested positive, what percentage successfully received the penicillin injection? We are measuring the performance of the delivery system, not the biological response to the drug.
Which brings us to the final stage, impact or the clinical outcome.
Right. Impact evaluates the ultimate epidemiological goal. Did the rate of congenital syphilis in that district actually decline? By measuring all four stages sequentially, researchers can perform precise systemic diagnostics. If the clinical impact is zero, they look backward. Did the delivery system fail at the outcome stage? Did the staff abandon the new workflow at the process stage? Or were the resources never delivered, an input failure? It allows you to pinpoint the exact location of the system failure.
Measuring these variables across multiple clinics requires study designs that can handle the complexity of the real world. We noted earlier that standard RCTs are often inadequate for implementation research. Why exactly do traditional RCTs struggle so much in this space?
The text outlines four specific methodological limitations of utilizing RCTs for complex implementation strategies. The first is number, or statistical power. In a clinical drug trial, the unit of randomization is the individual patient. You can easily recruit thousands of patients. But in implementation science, the intervention is often applied at the system level. Your unit of randomization is the entire hospital or clinic. You might only have 15 clinics available for study. Statistically, randomizing a sample size of 15 introduces massive risks of imbalance.
Yeah, that makes sense. And the second limitation is the challenge of balancing confounders.
Exactly. When randomizing individual patients in a drug trial, demographic variables tend to balance out across large groups. But hospitals are complex entities with deep structural differences. It is nearly impossible to guarantee that your intervention group and your control group of hospitals are perfectly balanced in terms of leadership competence, historical culture, baseline funding, staff morale. The interclass correlation coefficient, the degree to which patients within the same clinic share similar outcomes due to that clinic-specific environment, can heavily skew the data.
And the third limitation is complexity.
An implementation strategy like task shifting combined with a new electronic medical record involves dozens of interdependent variables that evolve dynamically. A traditional RCT requires locking down the protocol prior to the trial. It cannot accommodate the continuous, iterative adaptations required when a complex strategy interacts with a complex environment.
And the final, and arguably most frustrating, limitation is contamination.
Health systems are highly permeable social networks. If you randomize Clinic A to receive a highly effective new triage protocol, and Clinic B serves as the control, the clinicians in those facilities do not exist in vacuums. They attend the same regional conferences, they communicate. If the staff at Clinic B learns about the successful new protocol, they may independently decide to adopt it. Your control group contaminates itself, completely destroying the integrity of the randomized comparison.
Wow. So to overcome these limitations, implementation scientists have developed alternative methodologies. One of the most elegant solutions highlighted in the text is the step wedge design. This design is brilliant because it solves both a statistical problem and a profound ethical dilemma.
The ethical dilemma in public health research is acute. If you possess an implementation strategy that you strongly suspect saves lives, withholding it from a control group for the duration of a multi-year trial is ethically fraught. The stepped wedge design resolves this by ensuring every participating facility eventually receives the intervention.
Walk us through the mechanics of a stepped wedge. How does it control for variables without a permanent control group?
Instead of dividing your facilities into permanent intervention and control groups, you schedule a phased, sequential rollout across all facilities. Imagine you have 4 districts, A, B, C, and D. At the start of the study, no one has the intervention. They are all observed in their baseline state. In step 1, you roll the intervention out to District A. During this period, districts B, C, and D remain in their baseline state, serving as the concurrent control group for District A.
And then you just step it forward.
Precisely. In step 2, you implement the strategy in District B. Now, A and B are receiving the intervention, while C and D serve as controls. You continue this staggered rollout until all districts have adopted the strategy. By the end of the study, you have multiple data points comparing periods with the intervention to periods without it, controlling for temporal confounding, such as a sudden change in national health policy, because the crossover points are staggered over time. It provides robust, randomized data while ensuring equitable access to the intervention.
Another framework the text explores is profoundly philosophical in its approach to causality. It's called realistic evaluation, developed by Pawson and Tilley. It forces researchers to abandon the simplistic question, did the strategy work? And instead embrace the equation, context plus mechanism equals outcome.
Realistic evaluation posits that an intervention does not magically produce an outcome. Rather, the intervention provides a mechanism, a new resource, or a shift in reasoning that interacts with the specific context of the environment to generate an outcome. The core question becomes, what works, for whom, in what circumstances, and in what respects?
Let's apply that. Consider a performance dashboard that publicly ranks surgeons on their infection rates. The mechanism is peer pressure and reputational motivation. If the context is a highly collaborative, data-driven academic department, the interaction between that context and the mechanism of peer pressure might lead to an outcome of improved surgical prep. But if you drop that exact same dashboard into a context defined by a toxic, punitive culture where surgeons are already defensive, that same mechanism might lead to an outcome where surgeons simply falsify their data or refuse to operate on high-risk patients. The mechanism is identical, but the changing context dictates a radically different outcome. Realistic evaluation requires researchers to explicitly map these contextual interactions.
It's all about how the tool fits the environment.
Exactly. Let's transition from the theoretical frameworks to the front lines. In Section 6, the text provides remarkable case studies of these principles in action. Let's examine how this science is closing the gap in low- and middle-income countries, LMICs. We discussed task shifting earlier. The NIMART initiative in South Africa is a masterclass in how to execute it effectively.
NIMART stands for Nurse-Initiated and Managed Antiretroviral Treatment. South Africa faced the largest HIV epidemic globally, paired with a severe physician shortage. The traditional model, requiring a doctor to initiate ARVs, created catastrophic bottlenecks. Patients were literally dying while waiting for appointments. The proposed solution was to task shift ARV initiation to nurses. However, the implementation researchers understood the technology to systems gap. They knew that simply changing the legal scope of practice and issuing a mandate would fail if the nurses were already operating at maximum capacity.
Right, you can't just legislate an extra 4 hours into a nurse's day.
Exactly. The formative implementation research analyzed the system's constraints. They evaluated nurse workloads, clinic flow, and supply chain reliability. Based on that data, they didn't just train the nurses, they engineered the environment. They developed highly streamlined, nurse-specific clinical algorithms. They reorganized clinic flow to separate routine ARV pickups from acute care visits. They established clear, rapid referral networks so nurses could easily escalate complex cases to the few available physicians. By redesigning the context to support the new task, NIMART achieved a massive, highly successful scale-up of HIV treatment capacity.
Another powerful LMIC example is kangaroo mother care, or KMC, in Ghana. KMC is a high-impact, low-technology intervention for premature infants, utilizing continuous skin-to-skin contact with the mother to regulate temperature and promote feeding. The clinical efficacy is indisputable, but the implementation effectiveness required a really nuanced strategy.
In Ghana, the challenge was integrating KMC into busy, understaffed maternity wards. The implementation strategy utilized a combination of intensive, facility-level training to build the necessary clinical skills, coupled with a rigorous quality improvement feedback loop. Clinics were provided with specific data collection tools that allowed them to continuously monitor their own KMC adoption rates. This continuous feedback empowered local teams to identify their own operational barriers, such as, a lack of comfortable chairs for the mothers, and solve them iteratively.
We see a similar focus on operational flow in Ecuador, with the active management of the third stage of labor, AMTSL. Postpartum hemorrhage is a leading cause of maternal mortality, and AMTSL, which involves administering oxytocin immediately after birth, prevents it. But getting birth attendants to consistently execute the protocol during the chaos of delivery is difficult.
The implementation researchers in Ecuador approached the delivery room almost like an industrial process. They utilized continuous quality improvement methodologies to map the physical flow of the clinicians and the placement of supplies. By reorganizing the delivery room environment and streamlining the steps required to access and administer the oxytocin, they removed the operational friction. They designed the system so that executing the life-saving protocol became the path of least resistance.
We must also acknowledge the role of economic context. The Janani Suraksha Yojana program in India utilized a very different lever from our toolbox financial incentives.
This program tackled maternal and perinatal mortality by directly altering the patient's economic context. It is a massive conditional cash transfer program that provides financial payments to mothers, and sometimes the health workers who facilitate the process conditional on the mother giving birth in a formal health facility rather than at home. By removing the financial barrier and providing an incentive, the implementation data demonstrated a significant increase in facility-based births, correlating with reductions in perinatal mortality.
While these LMIC examples are profound, it is crucial to recognize that the chasm between evidence and practice exists everywhere. The text highlights a major implementation initiative within a high-income country, the United States Veterans Affairs, the VA, healthcare system.
The VA is the largest integrated health system in the U.S. Recognizing the persistent gap in delivering evidence-based care, they established the QUERI program, the Quality Enhancement Research Initiative. QUERI explicitly embedded implementation science into the operational fabric of the health system.
How did Query approach system redesign at such a massive scale?
They recognize that standardized protocols fail when they ignore local reality. QUERI developed a framework that assessed 3 specific contextual determinants before rolling out any new practice. Cultural norms like, how does the staff view the new intervention? Resource capacity, does the clinic have the staffing and space? And supportive infrastructure, does the IT system support the new data requirements? Using this framework, they successfully engineered the widespread implementation of complex interventions, including collaborative care models for schizophrenia, comprehensive HIV risk reduction programs, and systemic improvements in diabetic eye care. They treated implementation as a rigorous engineering challenge, not an administrative afterthought.
When you synthesize all of these examples, from South Africa's nurses to the VA's integrated networks, a profound realization emerges. Despite the grim statistics we started with, implementation science is an inherently optimistic discipline.
It is deeply optimistic. It rejects the fatalistic notion that our health systems are permanently broken or that human behavior is an insurmountable barrier. It operates on the foundational assumption that systems can be understood, dismantled, and redesigned. It proves that the logistical bottlenecks, cultural resistance, and systemic friction preventing the delivery of care are not mysterious acts of nature. They are empirical variables that can be studied and optimized.
To ensure these complex frameworks have successfully made the leap from theory to your own mental models, we are going to close with a practical application. Instead of a standard quiz, let's step into the shoes of an implementation researcher. Imagine you are tasked with leading the regional scale-up of a new, evidence-based protocol for managing severe maternal hemorrhage across an entire health district. The district includes 2 large, well-resourced academic hospitals and 10 small, understaffed rural clinics. As we walk through the planning of this rollout, we will highlight 5 critical decision points. I will pose a scenario based on the concepts we've covered. I'll pause briefly to let you, the listener, formulate your answer, and then the expert will explain the underlying principle and reference the corresponding section in the Oxford textbook. Ready? Let's begin the scale-up. First, your steering committee is debating the core focus of the project. The clinical researchers want to run another highly controlled trial to prove the hemorrhage protocol works. You argued that the protocol is already proven, and the focus must shift to studying the contextual factors and strategies required to get all 12 diverse hospitals to successfully adopt it. Question 1. In the NIH framework of translational research, your focus on real-world adaptation and scale-up aligns with which specific translational steps? Think about it for a second. You are operating in T3, translation to practice, and T4, translation to population health. You have moved past T2, which establishes clinical efficacy under controlled conditions, and are now engaged in the messy, context-dependent science of integrating evidence into routine care to impact population metrics. To review the entire translational pipeline, revisit the Locating Implementation Sciences section of Chapter 6.9.
Excellent. The project moves forward. Your team decides to deploy a combination of local clinical champions and mandatory staff training as your implementation strategy. Before launching, you design your evaluation metrics. You decide to track the percentage of clinical staff who successfully complete the mandatory protocol training sessions. Question 2. According to the 4-part evaluation framework, is measuring the completion rate of the training sessions an input, process, outcome, or impact measure? This is a process measure. It evaluates the fidelity with which your implementation strategy, the training program, is being executed. It is not an input, which would be funding or creating the training materials, nor is it an implementation outcome, whether the protocol was actually used on a bleeding patient or a clinical impact, maternal survival. For a deeper understanding of this measurement chain, review the planning measures section.
With the training underway, you realize you need a framework to understand why the training is succeeding in the academic hospitals but failing to change behavior in the rural clinics. You hypothesize that the training works by empowering nurses to speak up during a hemorrhage, the mechanism, but this only succeeds in facilities with non-hierarchical leadership, the context. Question 3. What evaluation framework explicitly structures its analysis around the equation context plus mechanism equals outcome to map these specific dynamics? Take a moment.
That is realistic evaluation, developed by Pawson and Tilley. It forces you to look beyond the simple question of, did the training work, and investigate the underlying social and cognitive mechanisms triggered by the intervention and how the local environment facilitates or inhibits those mechanisms. Revisit the Selecting a Study Format section to explore this paradigm further.
Now you face a logistical hurdle. You want to scientifically compare the outcomes of hospitals using the new protocol against those that aren't. However, the Ministry of Health has stated that intentionally withholding a proven maternal survival protocol from a control group of rural clinics for 3 years is ethically unacceptable and politically impossible. Question 4. What study design allows you to sequentially roll the protocol out to all 12 hospitals over time, utilizing the hospitals waiting for the intervention as your statistical control group?
You would utilize a stepped wedge design. This allows you to evaluate the intervention rigorously by staggering its introduction, controlling for temporal variables while ensuring that every facility eventually benefits from the life-saving protocol. To understand how to overcome the limits of traditional RCTs, review the control groups section.
Finally, a representative from an international donor agency reviews your project proposal. They ask why you were spending funds investigating the cultural hierarchy of the clinics and the cognitive load of the nurses. They suggest you simply use their existing monitoring and valuation framework, which just counts how many hemorrhage kits were distributed to the district. Question 5. You must defend your methodology. How does the primary focus of implementation science fundamentally differ from routine M&E?
You would explain that while M&E is crucial for measuring the services provided, counting the outputs, implementation science rigorously investigates the scientific etiology of the performance gaps. It asks why the kits aren't being used and tests hypotheses to redesign the system rather than just describing the failure retroactively. This distinction is the bedrock of the field. Review the Origins of Implementation Sciences section to solidify it.
Thank you for guiding us through the architecture of this incredibly vital science. We began with the image of a broken bridge, and we conclude with a comprehensive blueprint for how to engineer the connections required to save lives. As we wrap up, I want to leave you with one final, slightly provocative thought to consider regarding your own career trajectory. We have established, with empirical certainty, that the failure to implement a life-saving intervention causes just as much death and suffering as the underlying pathology of the disease itself. A cure sitting unused in a supply closet is functionally identical to no cure at all. So, if the failure of the health system is just as lethal as the pathology of the virus, shouldn't modern medical training dedicate just as much time to teaching us how to diagnose, navigate, and redesign complex health systems as it does teaching us cellular biology?
It is a profound question that really challenges the very structure of how we prepare the next generation of healthcare leaders.
Indeed. To ensure these frameworks become a permanent part of your clinical reasoning, please read Chapter 6.9 in the Oxford Textbook of Global Public Health alongside this discussion. Here are the details of this episode.
Implementation science, byline, closing the gap, translating evidence into real-world impact through disciplined implementation.